All right, hello everyone. In this explainer, we're going to tackle a situation that, if you work in elderly care, you've probably seen more times than you can count. We're going to walk through a complete patient pathway from an OT perspective for our older patients where alcohol use is a really big but often invisible piece of the puzzle.
So, let's set the scene. You've got a new admission on your ward. The reason? Recurrent falls. You've seen this 1,000 times, right? But what if what you see on the surface isn't the real story at all? That's what we're digging into today. Those hidden risks, and more importantly, the absolutely critical role that you play in bringing them to light. Okay, so here's our game plan. We'll start with that hidden diagnosis. Then we'll get into your specific role on the ward and how we loop in the rest of the team. After that, it's all about that crucial handoff. And we'll even look at a fantastic local service right here in Sutton. And to wrap it all up, we'll talk about making sure our patient gets home and stays home safely. All right, section 1, the hidden diagnosis. So, we're kicking things off with a patient story that is, well, it's super common on any elderly care ward. The catch is, the real reason they're with us is so often overlooked. So let's meet our patient. We'll call her Barb. Barb's 72. She's in the hospital because she's been falling a lot. The team's also noticed she's a bit confused, maybe not looking after herself as well as she used to. Now, your mind might be racing through a dozen different possibilities, right? But what if the thing that ties this all together is an alcohol use disorder that nobody, not even her family, has ever spotted?
And this is the absolute key, isn't it? Alcohol use disorder in older adults flies under the radar all the time. Why? Because the symptoms look exactly like what we sometimes just chalk up to getting old. The falls, the fuzzy thinking, the blood pressure that won't behave, not keeping up with personal care, even being a bit restless. All of these can be massive red flags for alcohol's role in their life.
Okay, so that brings us to your role on the ward. Once someone like Barb is medically stable, the doctors might start thinking about discharge plans. But hold on. The focus has to shift now, and this is where you, as an OT, really step into the spotlight. Look, your OT assessment is everything here. The doctors are quite rightly focused on the immediate medical stuff, but you're looking at the real-world consequences. You're the one who's going to spot the functional decline, pinpoint exactly where self-care is breaking down, and see the risks in their home that no one else is even thinking about. You're basically the detective connecting all the dots. And a really important tool in your toolkit for this is the SADQ, the Severity of Alcohol Dependence Questionnaire. Think of this as the gold standard. It takes us from just having a hunch to actually measuring the level of dependence. And that's absolutely crucial because that number tells us exactly what kind of help the patient needs. And here's why that score is so powerful. Look at how it breaks down. It's not just a number, it's a roadmap. If they score between 0 and 15, that's mild dependence. We're probably looking at a brief intervention. Simple enough. But if it's 16 to 30, that's moderate. That tells us they'll need an assisted withdrawal, but hey, that can probably be handled in the community. Now, a score over 30, that's a different story. That's severe dependence. And that score is a clear signal to everyone that this patient needs an inpatient, medically supervised withdrawal to be safe. It takes all the guesswork out of it. So, you've identified the problem. What's next? Well, now it's about connecting the whole in-hospital team, because this is not a one-person job. We need a coordinated response to give our patient the holistic care they deserve. And it really helps to know who's playing what position on the team, right? You've got the ward doctor. Their main job is medical stabilization, getting the meds right for a safe withdrawal. Then you have the fantastic alcohol liaison nurse. They come in, do their specialist assessment, and start lining up those all-important community referrals. And where do you fit in? Your functional assessment is the glue that holds it all together. It gives the real-life context that both the doctor and the nurse need to do their jobs effectively. Okay, let's talk about the crucial handoff. This, right here, is where things can go brilliantly right or terribly wrong. It's that moment where we pass the baton from the hospital to community support. It is, without a doubt, the most fragile part of the whole journey. And it's where you, the OT, can be the safety net that stops our patient from just disappearing into the system. And this quote right here, it just hits the nail on the head. The official guidance couldn't be clearer. You just can't discharge someone who's vulnerable, give them a piece of paper and say, good luck, go sort it out yourself. That's not good enough. The responsibility to make that connection, that's on us. So what's the solution? It's something called a warm handoff, and it's exactly what it sounds like. You're not just firing off a referral form into cyberspace and hoping for the best. No way.
This is about literally walking the patient over, metaphorically of course, to the next person. It's picking up the phone, making an introduction, and making sure that transition is personal and, actually happens. And if you want a great way to structure this, think IDEAL. It's a brilliant framework. I is for include, get the patient and their family in on the plan from day one. D is for discuss, talk about the important stuff, their home, their meds, what to look out for. E is for educate, and please use plain English, not medical jargon. A is for assess, and this is a good one. You use the teach-back method. Get them to explain it back to you to make sure it's landed. And finally, L is for listen. Just listen to what they're worried about. It's such a simple, powerful tool.
Okay, so we're talking about this warm handoff, but a handoff to where? Well, for all of us working here in Sutton, we have a fantastic local go-to answer for our patients. It's called Cranston Inspire. They're based at Orion House, just over on Cedar Road. You probably know it. They are, quite simply, our #1 partner for community alcohol support. They're the team that will pick up where we leave off. And just look at what they offer. This is the whole shebang. It's not just stop drinking advice. They do proper one-to-one key work. They support the family and carers, which is huge. They can arrange detox and rehab. They'll even help with practical stuff like housing and benefits. And they have a peer mentor program. This is exactly the kind of wraparound care we want for our patients. And here's the best bit. Professionals can refer directly. That means you can refer directly. You literally have the power in your hands to make that connection, to make that warm handoff a reality, and get your patient the help they need, fast. All right, last section. Let's talk about ensuring a safe return home. Because your job doesn't stop when the patient is wheeled out the door, does it? The planning you do before they leave has a massive ripple effect on their long-term safety and their life. And let's be really honest about why this is so important. When you, as an OT, manage this discharge properly for someone like Barb, you are directly stopping that revolving door of readmissions. You are making them safer at home, you're boosting their independence, and you're genuinely improving their quality of life. That's the impact you have. So what does this actually look like on the ground? Well, it's you doing that crucial home safety assessment to get rid of trip hazards. It's you sitting down with a family and teaching them what to watch for. It's you checking in to make sure they're actually connecting with Inspire, and it's you making sure the GP is in the loop for their ongoing care. It's all those practical OT things. So let's wrap this up. That gap between the hospital and the community, it's real. We all know it is. But it's not a canyon we can't cross. As an OT, you have this amazing, unique skill set. You've got the holistic view, you've got the practical tools. You are the person who can build that bridge. So the only question left to ask is, for your very next patient, how are you going to build it for them?